Thanks, Maury. Isn't this a great venue? I feel we should do some singing or something. Has anyone got some books to hand out? So I'm going to tell you a little bit about so-called second and third generation drugs in about the next 15 minutes before your coffee is due. The generation nomenclature is rather arbitrary. So it's just really to do with when they came into practice and development. There's nothing particularly different about the chemistry of them or how they're constructed. It's just really a timescale thing. But as you'll see, I think it's a question of using the right car to travel where you need to go. Sometimes you need a Mini, and it's fine, and it nips about. It doesn't go very fast, but it gets you there. Sometimes you need a more powerful engine and something that gets there a bit quicker. So I'll talk you through that. So as well as having some research funding from these companies, a large part of my professional life now is working at NICE. So we've heard about accessibility to medicines and affordability, particularly with generic imatinib. But I think we're in a fantastic position in the UK, the NHS, that really all of the medicines that we're talking about today and any of the situations I will describe to you about when you might use them are available and funded without you having to worry about that. That wasn't necessarily the case 5 or 10 years ago, but by and large we have access to all the things that we need to do and need to use for treating CML effectively. So I want to cover 3 broad areas. Firstly, what's actually available, and you've heard of some of the medicines already, but just to dive into a bit more detail around that. Secondly, just a few things to think about. Some of them are very straightforward, some of them are less straightforward, and then finally, some thoughts about how you might choose or come to the conclusion with your doctor about what's right for you. I'm very conscious that you're here at this meeting because you've either got CML or you have a family member or friend or relative who's got CML. So you're not going to be thinking about what to choose first line, but you'll be on some form of treatment and you might be interested to know what the thoughts are around choosing first line therapy. So what have we got available? Basically there's 5 drugs. Gleevec or imatinib, you've heard quite a bit about already. It has been around now for coming up for 20 years, about 18 years. And after that, we've had a number of different drugs have come to the fore. So we've got Sprycel, Tasigna, which is dasatinib and nilotinib, Bosulif or bosutinib, and the latest coming to the party was ponatinib or Iclusig. And this just shows you how these developed over time. And it's actually relatively recently, you'll see here, these green blocks on dasatinib and nilotinib, that these so-called second generation drugs have been available for first line therapy. When they first came in, we had access to them for second line. But now really the top 3, so I guess imatinib is first generation, dasatinib, nilotinib, bosutinib are second generation, and ponatinib third generation. We have access to the top 3 for first line therapy. And the second and third, i.e. nilotinib, dasatinib, and bosutinib for second-line therapy. Bosutinib isn't going to be available for first-line therapy, and ponatinib is held in reserve because it's probably the most potent, but possibly has the most side effects as well. So this is what that looks like in a table. So although in theory you could use imatinib second-line if you'd chosen something else first-line, it's very rare that that actually happens because most patients, and I think it's quite appropriate, even though it's the cheapest form of medicine with the generic imatinib, most patients, when they're first diagnosed with CML in this country and probably throughout the world, still go on imatinib. As you've heard, it's been a huge success story, imatinib, in terms of a cancer treatment. The second generation drugs have their advantages, and I'll show you, but in terms of survival, which is probably the most important to all of you, then there's actually no advantage for these newer drugs, as I'll show you in a moment. So that's the kind of landscape of what's available first and second line. So a few things to think about, and I'm going to focus on first line treatment to start with. So I know you're not making choices about that right now. You'll be on some first line therapy, a lot of you, but here's some thoughts just to reassure or inform how that decision was made for you perhaps. So imatinib, pretty much the standard of care still, and I think it will be for the foreseeable future. I can't see, but I may be wrong, that imatinib's place as the top of the heap, as it were, will be usurped anytime soon, because it's very difficult to show a survival benefit that's greater than imatinib because it's already so good. It's been around for 18 years. That's a long time now in terms of drug experience, and we know it's pretty effective and it's pretty safe. We're not seeing any scare stories really with imatinib after that long period of follow-up, and as you've heard, it's relatively inexpensive. It's about 2 or 3% of the original cost for many of the generics. So the second generation drugs, those are the 4 things that I think are worth considering and thinking about. So better and quicker PCR results, is that important for you? Is it helpful? What about the side effects of these things? What about survival? Because obviously we all want to survive, and especially if you've had a diagnosis of leukemia, that's one of the most important things for your treatment. Expense I'm not going to really talk about a lot, we've covered it a little bit, but it's a minor-ish consideration for you as an individual. So there's no doubt that the second generation, and if you like the third generation drugs, the newer drugs for CML produce better and quicker results. So I've just taken one particular graph from a particular trial that happens to be dasatinib, but if you do the same with nilotinib or with bosutinib, the answer is the same. So a little bit technical, but let me talk you through it. These curves step up every time a patient gets the response in question here. And this is major molecular response. So you've heard about that from Kate's talk. That's getting to a very low level, less than 0.1% with your PCR test. So it's a good place to be. And you can see here on the imatinib treatment arm in this trial, and there's several hundred patients involved here, a pretty good proportion of patients achieved that landmark, that important milestone. But you can see that more of them on, in this case, dasatinib, achieve that, and generally they achieved it quicker. So if you care about your molecular response, and you should to some extent, but it's not the only game in town, then you could argue that the newer drugs are better because you're getting there quicker and a larger number of patients are getting a deeper molecular response. So that's a good thing. Does that mean necessarily that these drugs are better? So again, to use my car analogy, if you were driving from Birmingham to Manchester in your Mini, it might take you 2.5 hours, especially with the traffic on the M6 these days. If you were doing it in a Porsche, given the traffic on the M6, it probably would take you the same amount of time. But if the road was clear, you might get through quicker. But you know, you'll still get to Manchester. Does it matter that you got there half an hour later with a smaller car rather than going in a Porsche? And in terms of survival, the answer is probably not. But Kate mentioned before about a younger patient, a younger woman who wanted to consider starting a family. If you want to optimize your chances of getting to a very low level and possibly being able to stop, possibly being cured, and we'll hear more about that this afternoon, then maybe one of these newer drugs is a good choice for you. And I think if you're younger, and the risks that I'll talk about in a moment are not as great for you as a younger person, then that's a pretty reasonable thing to do. What we're not certain about, though, and you'll hear from Professor Clark this afternoon all about the ability to reduce and stop treatments, we're not sure whether these newer drugs necessarily lead to a higher proportion of patients being able to successfully stop treatment in the longer term. There's ongoing trials about that. So there's some uncertainty, but if there's little risk to you, then you know a second generation drug might be a good thing if you want to get a deep response. The trouble with that is that there's a price to pay, not only a financial price, but potentially a side effect price. And again, if you're younger, that might not matter, but CML is largely an illness of older patients. So balancing up the benefits and the risks is absolutely critical in judging which is the right treatment. So in terms of side effects, this is a very simplistic summary of many years of experience, but I think reflects what we probably feel as clinicians. That imatinib, it might have a few troublesome things, like you'll get slightly swollen tissues around your eyes sometimes. It can affect your stomach a bit sometimes, but generally it's pretty safe. With nilotinib, and at the bottom there, ponatinib, there's been this concern about blood vessel problems, so clots in your legs, for example, heart attacks and strokes, which is obviously something you want to avoid. It's quite difficult to pin that down. It's not a huge risk that everyone encounters. It's a relatively low risk, and it's difficult to be sure in a population what the contribution of the drug is. So if you take people who are 65, who smoke a lot, who have problems with their cholesterol, who have high blood pressure, family history of heart disease, then of course they're going to be at risk of having those problems anyway. So working out what the additional risk is of putting a drug into the equation is not straightforward. So we can't be absolutely sure, but there's a pretty well-established sense now, based on the evidence, that nilotinib and ponatinib are slightly risky in terms of cardiovascular problems, as we call them. And nilotinib tends to mess with your blood sugar. So if you're diabetic, that already puts you slightly higher risk of having cardiovascular blood vessel problems. You might want to avoid nilotinib, for example. The thing that happens with dasatinib as the most common side effect, and it's not life-threatening, it's troublesome more than dangerous, is this thing called pleural effusion, which means that you collect fluid in the space between your lung and your chest wall. That's what a pleural effusion is. We don't really know why that happens with dasatinib, but taking all patients and all ages, it's about a third of people will get a pleural effusion at some point, and it can take years to develop. So if you've got a bad chest or problems with your heart already, and it's not pumping well, for example, you might want to avoid dasatinib. But again, if you're in your 30s, with little of those risks, then dasatinib and nilotinib are probably very low risk. Bosutinib seems to not have these troubles I've mentioned before, but quite often causes diarrhea, which can be a dose-related effect. Sometimes it goes away over time. So you'll see that although there's a benefit with a better molecular response with many of these things, there's also some troublesome side effects. Some are troublesome but not life-threatening or serious. Some are actually quite serious if they happen to you. So there's a balance. So I mentioned before that there's no improvement in survival with the second-generation drugs, and I just want to show an illustrative slide or two about this. You can't really see the difference between these three lines here because there isn't much, and statistically it's not significantly different, as we'd say. So these happen to be curves of the rates of progression to more advanced disease with imatinib and nilotinib. And this is the result from the trial that we've been doing in the UK for the last 5 or 10 years, Spirit 2, which you can see there. It's almost hard to tell if there are two lines, but there are two lines, and they're exactly superimposed, which means there's no difference whatsoever in survival, even though you're seeing a higher rate of molecular response. Reassuringly, you can see the numbers here. This can be a bit hard to look at if you've got leukemia and you want to see these, but if you have some types of leukemia, these curves are kind of down here. They're not very good at all. But as you've heard earlier today, the survival with CML with modern therapy is fantastic. And hardly anybody in this trial, about 2% of all the patients died from their leukemia. So I think that can be very reassuring to you, that the survival is excellent these days with modern therapy, whichever you choose, including imatinib. Expense we've touched on, and I'm not going to labour in any greater detail. So I think for most people, first line, if you want to get from Birmingham to Manchester, a Mini's fine. And if I got CML tomorrow, I'd happily drive a Mini. I'd have imatinib. But I think reserving the more powerful beast for situations where you are not doing so well, however we define that, or perhaps when the Mini hasn't suited you, you've not been able to tolerate the imatinib, it has a place, or they have a place. So what about second-line treatment then? We've focused mainly on first line. How would you, or when would you, choose to switch your drug of choice? I'm not going to go over all this again. You've heard very nicely from my colleagues what the levels of PCR and various tests are that would make you think about switching, and you've seen some very nice examples of that. But broadly speaking, clearly if you can't tolerate your first-line treatment, then we'd explore second-line therapy. And people often ask me, what should I choose? If I'm on imatinib and I can't tolerate it, should I go for dasatinib or nilotinib? And sometimes if you're diabetic, as I've said, if there's lots of concern about cardiovascular, I might err towards disapanib. If there's absolutely no concern whatsoever, it's almost toss a coin, I think, if there's no mutations and things like that evident. So sometimes it's easy, you have a genuine choice, there's not much difference. Sometimes it's determined by your other medical problems and other factors that are individual to you. But switching treatment if you can't tolerate it is an obvious requirement to change to second-line therapy. And then broadly speaking, there are two other contexts. You've seen from Kate that we routinely watch the PCR levels and the blood counts and everything else as you're going through your treatment for the first 6, 12, 18 months. And if they are not ideal, we might consider switching them. That definition of not ideal can be difficult, though. And Kate again has said, there was a patient who was tolerating their second-line treatment very well, but maybe the results weren't perfect, and they chose to stick on with that. And I've seen quite a lot of patients where the results aren't perfect, but they've actually done fine. So you have to weigh all these things up a little bit in making that decision to switch or not to switch. And it's to some extent time dependent. So it takes a while, 6, 12, 18 months, to get the best response you're going to get on your treatment. So patience is required, I think, sometimes to see how you're going to do. What I think is a bit more straightforward is if those results have been good in the past, then they've now got worse. So things that are easy for us to make decisions on as docs are if your blood count goes wonky, if it's been completely normal, and then your white blood cell count goes up to 20 or 30, and you've been taking the drug reliably, that's a very clear-cut indicator in my mind that you need to switch. But that's actually quite rare because the medicines work very well. The more difficult one to balance up risk and benefit is, PCR has been really good. Maybe it's less than 1 or 0.1%, and now it's going up a little bit, and then it's down, then it's up a bit more. Those are more finely balanced decisions. And I tend to get a bit more interested in switching when the PCR goes above 1 and keeps on going north. If it's hovering between 0.1 and 1, I'm going to wait a little bit and see how things are and weigh up those other factors that I've been telling you about in terms of risk of those other drugs. So a few things to think about there. And when you're considering what's right for you, I think there's basically a balance to be struck between all of these things. And there are three things, I think, particularly, that have to be weighed up. It's going to be your wish to stop treatment completely, your consideration of other potential risks for you and your medical problems, and also whether you're happy to keep on taking tablets. So for imatinib, for example, it's going to be a minority of people who are going to be able to reduce and stop treatment, as you'll hear this afternoon. So for most of the people taking imatinib, they're going to be on it for life, which is taking the view, I suspect, that CML in that situation is not being cured, so you have to take these things forever. But then lots of medicines in medicine are taken forever, so cholesterol pills, your diabetes medications, blood pressure pills, very common to take treatments for many, many years which control diseases but don't cure them. And again, personally, I wouldn't be that bothered about taking pills for the rest of my life as long as I could tolerate them okay and I could remember to take them every day. But if you're younger, you're in a hurry, you want to explore that higher chance of stopping, the risks for you are less, then it's very feasible, reasonable to explore using these newer drugs in that situation. So these are the things that we're going to be kind of weighing up. How you're doing, generally speaking. That's a factor of your blood count, your PCR, how you're tolerating these treatments. Over here on the right, what risk factors have you got that would influence that decision to switch therapy? And also, you may or may not mind taking tablets forever, so that's a practical consideration as well. So I hope that's given you an idea of what's available, of what the thinking is about choosing first-line therapy, about weighing up the risks and benefits for you as an individual for second-line therapy, and I'm happy to take any questions. Thank you.
So I think I'm conscious that it's coffee break time and question time now is going to eat into coffee break. So if we maybe take 5 minutes to take a couple of questions just now, and we have got some time at the end of the day to do a longer question and answer session. So are there any questions in the room? So, Ruth? Oh.
My diagnosis was in January 2017. I was on imatinib. Recently we changed to dasatinib because my PCR was wavering between 1% and 2%. I know you've been talking about changing, there is changes do happen. Is there any evidence as to why that happens or why they think that dasatinib is more effective?
Did you say dasatinib you switched to?
Dasatinib, yeah.
So why does it happen? Sometimes there's a cause that we can find. So I suspect most of us in the situation you faced, where PCR is not brilliant, but it's sort of okay, would probably do a mutation test. So if the BCR-ABL, or the ABL part of the gene, changes slightly with a mutation, it can change how the drugs stick to it, or the protein from it, and therefore change the way they work and make them less effective. It feels to me like when I do that test in people like you, where the PCR is kind of pretty good actually, but not brilliant, I'm going to say half the time, or at the most, do I find a mutation. So for the other half, you're not finding that, and probably more than that actually. And in those situations, we don't really know. There's lots of research been done on that over the last sort of decade or two, but if you don't find mutations with a comprehensive screen of that area, it could be that there are other genes are mutated, which cooperate in some way with that, which we don't understand very well, or it could be other mechanisms of clearing drug in a particularly fast way that we don't particularly understand well either. So sort of is the answer to your question. We sometimes understand it, but often we don't. And one thing to say actually about that, I always ask people, are you actually taking the medicine? Because it doesn't work unless you take it. And I've yet to have anyone confess to me that they haven't taken it, apart from one individual I can remember. But there's a lot of work again been done on compliance or adherence, as we call it. And if you don't take it reliably, then that can cause problems as well, of course.
Yeah, there were no mutations. They said it was the same as at the beginning. So
Yeah.
that's also a bit confusing. But as you say,
Well,
I don't know the reasons for it.
But perhaps reassuring. You probably don't want a mutation if you can avoid it.
No.
Something you'll actually be able to answer. It's more reassurance I'm looking for. And given the present kind of climate politically and a lot of scaremongering round about the provision of medication post-Brexit, I'm just interested on your, do you have any information on that, or do you anticipate that being an issue in the future?
Don't get me started. So we can have a political discussion. I think it's nonsense, frankly. Particularly for you guys, is anything going to change with regard to the availability of the medicines for CML and or NICE guidance? No.
Okay,
Been doing really well. My 0.046%. I'm a nurse. I had 11 months off sick initially, then went back to work, very part-time. The only thing that I find, and I'm sure probably every other person like me finds, is the fatigue. The pain in the shoulders, the itchy spots that aren't so bad now. Being very thankful that I'm even here, because I realised 20 years ago I wouldn't have been. It's about quality of life, really, and I suppose at times now I begin to think, listening to what you've just said about the imatinib, I've got a history of high blood pressure, but that's been managed for about 20 years, and that's been okay. At times I wonder with the imatinib, if it has less side effects, would you go back from nilotinib to imatinib or not?
It's a really good question. Could I ask you a question in return, which is, how come you went on nilotinib first line?
I was put on nilotinib to start with.
Yeah, but did you choose that, or was that your doc's recommendation?
My consultant, I think it was, my illness was probably picked up quite early.
Yeah.
I knew, as a nurse, I knew there was something terribly wrong with me for about a year.
Yeah.
I thought I'd got ME, I kept going backwards and forwards to the doctor, didn't show anything. Then I rang him again, he'd referred me, hadn't been seen, hadn't had an appointment, so I rang him. He said, right, do another set of blood tests. The white cells went up, the blood platelets suddenly shot up and got me in within a few days.
Yeah.
It was all brilliant. But
Yeah.
when I saw the consultant, she said straight away, because I'm 63, I was 61, you're relatively young.
Yeah.
This drug will work very quick, it's very potent. I want you to go on this.
Yeah.
So they started me on it. I hadn't even had the bone marrow biopsy. I hadn't had all the results. She said, I know this is what it is. So I was started on it. And I have been really good with it. I work 15 hours a week. I've been good with it. But at times now, the fatigue and the feeling breathless, which possibly other people have as well, I think as a patient, not a nurse, as a patient, how is that normal? Do you have variance between this fatigue and that? Would it change if I was on imatinib?
So let me try and answer that fairly quickly, because we all need coffee, I think. A couple of thoughts, really. The first is there's very little evidence to guide a decent answer to your question. There isn't a big study with lots of patients who started on nilotinib and then switched to imatinib. So the honest answer is I don't really know. However, I suspect if you've had very good responses to nilotinib, chances are you'd probably, from a PCR point of view, respond well to imatinib, but there's no guarantees about that. And thirdly, you wouldn't know until you tried it. I think fatigue is something that we don't pick up enough, actually, as doctors in the clinic. We're in a busy clinic. People, they come in, the blood count's fine, the PCR's okay, we talk about the weather a little bit. Sometimes we don't listen enough, I don't think, to more subtle things like fatigue and other things. And it's always good to come to meetings like this and hear about these things in a more relaxed environment sort of thing. So I think it's probably more common than we pick up. Whether you'd feel less fatigue on imatinib, I'm not sure. It could be a dose effect as well. So if you're responding very well and having some fatigue, there might be some room for reducing dose of nilotinib or any of these TKIs in view of the side effects. So you have some options, but I can't be sure for you whether any of those choices would necessarily improve things.